Good afternoon to all, and we want to welcome you to today's CPD. We'll start with a short prayer by Dr. Bernard Hammond. Dr. Bernard Hammond, kindly lead us in a word of prayer. Thank you.
Shall we pray? Father, we thank you for today. We thank you for this lesson. Even as we meet to share knowledge, may it be a fruitful time, may it be something that will improve our practice and impact life. If we ask in Jesus' name, amen.
Amen.
Good afternoon. My name is Dr. Aisha. I'm going to be your moderator for this much-awaited CPD. And first of all, I'd like to do all due diligence and acknowledge all on board. Special acknowledgement to the team who put this CPD together. Then the National Executive Council of the Ghana Medical Association as well. All health workers on board are also duly acknowledged. This is a free CPD on priority diseases under surveillance in Ghana, and it's organized under the auspices of the Ghana Health Service and then the Ghana Medical Association. Before I proceed, I would introduce the chairman, and the chairman will give his address. Then we will go on to have our speakers. Question and answers will be in the chat box, and then the speakers may address them directly in the chat box, or after their presentations, there will also be an oral question and answer session before the closing remarks and prayers by our honorable chairman. So I would our chairman for today is the acting chairperson of the Ghana Medical Association Committee on Professional Development, on Continuous Professional Development, and he's a divisional chairman of the Volta Division. His name is Dr. Kweku Apj, and he is going to be our chairman for today. So, Mr. Chairman, your audience, your chairperson. Thank you.
Okay, thank you very much, Dr. Aisha, for the brief introduction. On behalf of the National CPD Committee and on behalf of Dr. Frank Shribor-led National Executive Committee, I want to welcome all colleagues and other health workers who have joined us for this important meeting. We were tasked as a committee to come up with relevant CPDs that will meet the needs of our members. And we thought that having a CPD on such a topic would be something that would benefit all. We are grateful to the Ghana Health Service for coming on board. I'm sure we are going to enjoy this session looking at the lineup of speakers that we have. At the end of the presentation, would come back to you to give us our closing remarks. So I thank the committee for the honor that they've done for me to chair this particular session. I am grateful. Dr. Aisha, we can continue. Thank you.
Thank you, Chairperson. So we are going to have the speakers in the following order. Dr. Dennis Laye will speak first, followed by Dr. Azuma Abdul Tawab, then Dr. Holali Ujinu, then Dr. Joshua Arthur will conclude. So I'll give a brief introduction of Dr. Dennis Laye before he comes on board. He is a senior public health physician specialist and currently the surveillance lead for the Public Health Emergency Operations Center of Ghana. He's also the Deputy Director, Surveillance for the Ghana Health Service. He is going to take the topic on Introduction to Integrated Disease Surveillance and Response. So Dr. Dennis Lai, please, your audience.
Thank you very much, Aisha. Let me just share my screen. And thank you, Chair, and appreciation to the GMA for giving us this platform to be able to have this very important discussion as the Chair for the occasion indicated. CPD on priority diseases under surveillance in Ghana. Maybe I'll just give a quick brief background on why we in the department think that this is important. And personally as well, this is important for me, given where I've come from my days in Confanochi Teaching Hospital, where one of the things I noticed with our house officers in particular was the lack of appreciation of what is expected to be done if we suspected a priority disease. In fact, even the first point was about whether we knew what the priority disease conditions were. And fortunately, a senior colleague as well, so one of our consultants, I'm sure he's on the call, and he probably would not be happy I bring this up, but I'm still going to say it because he gave an example of how he used to make or confirm several cases of Brule ulcer in Confanochi Teaching Hospital, but made no effort because he didn't know that these cases are to be reported as a priority disease under surveillance in Ghana. And so for me, this was a gap. And when I was in Cath, I remember we introduced priority diseases under surveillance as part of the house officers orientation at the Confanochi Teaching Hospital. So this is a bigger platform, and I'm really hopeful that by the time we're done with this, colleagues, not just doctors, but all of us would have received some information that will be useful in our practice. So my team, and these are objectives the team came up with, myself, Dr. Gujino, Dr. Arthur, and Dr. Taab, and some colleagues from the disease surveillance department. Our CPD objectives are: one, introduce participants to the integrated disease surveillance and response strategy. Just an introduction. I don't think that in this workshop we can be able to cover IDSR as we know it, but at least introduce. And then highlight the role of clinicians in the implementation of IDSR in Ghana. And then we also want to introduce participants to the updated priority public health diseases under surveillance in Ghana, and then to review case definitions for priority diseases under surveillance. We'll discuss reporting and laboratory testing for priority diseases, particularly with emphasis on where the samples should be sent to. Testing for public health priority diseases are generally free. COVID was the only exception, but otherwise for all priority public health diseases, once they are sent to the designated laboratory, the testing is free. So part of our presentation would look at this. And if there's the opportunity for discussions, we'll look at how we can strengthen particularly clinician involvement in IDSR implementation. So these are our objectives, and the outcomes at the end of this workshop. We're expecting that there will be an understanding of the basic concepts of IDSR. And yes, there are 55 priority diseases, conditions, and events under surveillance in Ghana. So we should all, at the end of this meeting, be familiar with these 55, and then gain some clarity on the roles of clinicians and other healthcare workers on the roles as far as disease surveillance and response in Ghana is concerned. Beyond this workshop, the key thing for us in the department is to see clinicians being actively engaged in the detection and reporting. I'm sure detection is not an issue. Reporting and ensuring that appropriate investigations of these priority diseases, conditions, and events are done is our long-term goal. So beyond this workshop, this is what we would want to see. And I know that colleagues were saying that if we're not careful, we'll be getting a lot of suspected cases, but that is something we are not worried about. So I'll zoom in now to the topic I have been given, which is to introduce us to the IDSR strategy. This will be the outline, brief background. We'll look at the objectives, surveillance functions. We'll look at the relevance of IDSR in the clinical setting, the role of clinicians. We try and discuss clinical diagnosis versus our case definitions. I'm preempting that because the case definitions will come up later, and I'm sure some questions will come up in that line. And then we'll share some thoughts on how we think clinician involvement in IDSR implementation can be strengthened. So IDSR is a strategy for public health surveillance and response and to priority public health diseases, conditions, and events. And it was developed taking into consideration the unique characteristics as far as human resource availability and distribution in Africa is concerned. So the WHO Africa region developed this in 1998, and it's not only focused on those of us in the formal health setting, but is also applicable for some sections at the community level by community members and also community health volunteers as it were. So what the WHO does is to give a template guideline, and then countries are expected to adapt. And so what I have, the two pictures I have on the screen, the upper one is the WHO, the current edition, which is the third edition, and for which Ghana has adapted, which is what we have at the bottom. And we will be sharing soft copies along the line for all participants to be able to download and review. There are 6 booklets in all. So I mentioned it started in 1998. Ghana adopted it in 2002, and we've undergone 3 revisions so far. So as we can see, there are 4 different booklets. The first one, on the upper left, is the first edition. Then to the right was the second edition. We revised the second edition in 2017. So first edition 2002, second edition 2010, revised second edition was in 2017, and our current edition was 2020. And it's aimed across all levels, from the community all the way to the national level. So let's try and get some basics. First of all, let's look at surveillance. For students of public health, this is one of the definitions that you can never run away from. So it's an ongoing systematic identification, collection, collation, analysis, and interpretation of disease occurrence and public health event data. So it's not just about diseases, but also things that have implications for public health. And the reason we do this is to be able to take timely and robust action. So if the information, if the collection, if the analysis, if the interpretation is not done in a timely manner, then our decision-making will be delayed. Our actions will be delayed, and that could mean a large-scale outbreak instead of a few cases. Now, if we look at public health surveillance, and I took this from Gilbert and Cliff from a publication in 2016, where they look at all the contributors to public health surveillance. And I think that this captures it quite well. So one of the things I want us to do, all of us on this call, is to look at the various boxes that surround the public health surveillance ellipse and ask ourselves, which one of them do we fit in? Which of these data sources are we part of? Is it health records? Is it laboratory records? Is it disease registries? Wherever we find ourselves, we are contributing to public health surveillance one way or the other. And there are various types of public health surveillance. We have what we call the indicator-based surveillance. IBS, I'm sure it means something else in other circles, but at least here we're talking about indicator-based surveillance. So this is where it fits into the definition I mentioned earlier on. So it's very systematic, it's structured data that is collected, and there are indicators produced by these. And the data is collected mostly from health-based formal sources. So health facilities, laboratories, and the likes. Whereas we have what we call the event-based surveillance, and this has become very critical in this current age where information flow is very, very rapid. And so sometimes those may be sources to act more rapidly than to rely on our health system, which may sometimes be delayed. But this one, even though there's organized collection and monitoring and assessment, the data that is being collected is usually unstructured and is ad hoc information. So it's about events or risks which may present or may represent an acute health risk. Now, one of the things I want us to bear in mind, we'll go into details later in subsequent slides on event-based surveillance where specific examples may be given. For indicator-based, again, there are subtypes, but for most of these, they just, overlap. And so a facility-based surveillance may, for example, include laboratory-based surveillance as well. And so these definitions are just there, if you ask me, for academic purposes, but at least for us to know that there are various types under indicator-based, one of which is facility-based, as the name suggests. So this is what is done within health facilities. And for example, they may be required to report immediately any epidemic-prone disease to the district health directorate, which will be the next level. And then we have laboratory surveillance. So laboratory surveillance, laboratory-based surveillance may be conducted for various reasons, including lately genomic surveillance, but we also know about antimicrobial resistance, and we could also even just be looking at surveillance for specific pathogens and their antibiotic sensitivity patterns. So this is another form. And then we have the case-based, which basically means that every individual case is recorded using what we call a case-based form, which currently we have it as an electronic platform. Again, that will be discussed in later presentations. And then we have syndromic surveillance, which uses standard case definitions and is based entirely on clinical features. So the issue of laboratory testing doesn't come in, at least not at the syndromic surveillance stage. But if we need to move beyond that, then laboratory testing would come in. And then we have sentinel surveillance, where it may be for specific pathogens or may also be a proxy for estimating a disease burden. So currently we have respiratory pathogen surveillance, sentinel surveillance in all 16 regions. And the map on the right is showing the location. So every region has at least one pathogen sentinel surveillance, respiratory pathogen sentinel surveillance sites. We can see that regions like Greater Accra and the Western have multiple sites, largely due to these sites located in some military health facilities. So those are the common types of indicator-based surveillance. And then we have the community-based surveillance, which I think I mentioned earlier on. And that is a combination of event and indicator-based surveillance, because we do have some documentation for community-based surveillance volunteers, which could qualify as indicator-based. And then they are also required, or as part of their training, to be looking for some information and reporting them informally. So this includes rumors of anything, unusual number of people falling sick, number of people dying, animals dying, anything that they feel should be reported or notified to the health system. These can also be done. So the community-based surveillance system, as we practice in Ghana, combines EBS and IBS. People like to compare sometimes, and so we'll just attempt this here. So for event-based surveillance, it is not based on routine monitoring of indicators, and there are no automated thresholds. So for example, if you take a disease condition like meningitis, for indicator-based surveillance, there are thresholds set. If you get a certain number of cases within a certain week over a certain population denominator, then a certain level would be deemed to have been reached. But this is not the case when you talk about event-based surveillance. And again, event-based surveillance is based on screening of all available information to detect any event, anything that's happening in the community, unusual disease, unusual deaths in humans or animals, unusual clustering of cases or events or conditions. Anything that may be considered to be potentially a health risk can be reported to the health system as an event, and the health system would then investigate this. And by health system here, I mean for the bigger facilities, this will be the institutional public health units or departments. And then for the smaller facilities with that public health units, this will be the district health directorate. So there are surveillance functions, 8 of them. I'll just run through. This session is focusing on steps 1 and 2, which is the identification and the reporting. But there are other things we do, and that's mostly for those of us in public health, even though along the line we bring others in. So for example, we analyze the data and try to interpret. We do investigate and confirm suspected cases or outbreaks or events. We put in measures to prepare and to respond, and risk communication is part of this. And of course, monitoring, evaluation, supervision, and provision of feedback are hallmarks of the surveillance system. Now, IDSR is a concept, is a strategy which talks about integration, and this is aimed at maximizing the efforts among all disease prevention and control programs. So we don't want silo systems, even though we haven't gotten there as a country. As far as epidemic-prone diseases are concerned, this is being practiced, and so we don't have designated persons for specific diseases at the district level. The district runs the surveillance system holistically, and this ensures that the utilization of resources is harmonized and optimized. The other bit is also about training. So we don't do individual training sessions for individual disease conditions. The trainings are usually done across board for all the priority diseases. And in the same way, when supervision or monitoring activities are being done, it is done across board for all the priority diseases. And remember, I mentioned that this was developed by the Africa region. And one of our key challenges in this region we know is financing. And so it's important that we integrate to be able to ensure that these things get done and done well. So rather than using scarce resources to maintain multiple surveillance systems, we have one system, and the district level is the hub for surveillance. And this runs to the national, through the regional levels to the national levels. So the objective of IDSR in Ghana is to improve the country's ability to detect, report, confirm, and effectively respond to high priority, communicable, and I have to stress this, non-communicable diseases. Because oftentimes the thinking is that it's only for communicable diseases, but it's also for non-communicable diseases. The specific objectives are quite a number, but I'll focus on the first 2 for the purposes of time, but we will share the slides and we can go through all the other objectives. So the first one is to strengthen the capacity of the country to conduct effective surveillance activities. And this is by building capacity at all levels, including health, training, and academic institutions. And when I was giving the background, I mentioned that our training sometimes at the pre-service level does not equip us with the necessary skills or capacity to be able to implement IDSR. And so this is one of the key objectives as far as IDSR is concerned. The second objective is to increase involvement of clinicians and other cadre of health staff in surveillance activities. Now, the use of increase presupposes that there's suboptimal involvement of clinicians in disease surveillance activities. And that's why we're looking at strengthening the increasing the involvement of clinicians and other cadres of health staff in surveillance activities. And there are other specific objectives, which we'll look at that later. But the key thing at the end of it is for us to contribute to improving and strengthening public health research, which I'm sure is of importance to colleagues, particularly in academia. So who are supposed to be the targets for IDSR in this country? And as you can see, there's a very tall list. I've boldened or highlighted some of them: physician assistants, public health staff, medical doctors, nurses, pharmacists, medical and nursing educators, health training institutions. These are very important. And the implementation of IDSR starts fundamentally with the use of case definitions. And so we'll have a whole session on case definitions, but it's important that we are conversant with these case definitions. So sometimes the thinking is that, look, this is surveillance, this is public health. What has that got to do with clinical practice? I mentioned that IDSR implementation involves the use of case definitions. And before I even go on, again, I want to use this illustration on the right, where there's Meha and Ford look at public health and clinical medicine and look at the areas of intersection. And these are disease control, quality of care, research, ethics, guidelines, training, and management. These are things that we share in common. And particularly with disease control, surveillance is the basis for disease control. And I've mentioned that case definitions form the basis. So in the clinical practice, IDSR can support clinical suspicion and appropriate investigation of clinical cases. And this is through the use of case definitions. The other one is to guide clinical decision-making, including appropriate IPC measures. So IDSR says that if you suspect COVID-19, what are the IPC measures to take? If you suspect an acute hemorrhagic fever, what are the measures to take? If we don't take these things, then we are putting our health staff or ourselves as clinicians at risk. So some guidance for clinical decision-making and also opportunity for establishing linkage. IDSR tells us about case definitions, about looking for cases, about linking cases up. And so as a clinician in the consulting room, as a nurse in the ward, if we see multiple cases of similar presentation, is there the question IDSR would want you to be asking? Is there a link between these? Why are we seeing these cases from this location and what in these numbers? So these are things or opportunities that IDSR would provide if we are very conversant with that. And last but not least, protection of clinical staff in particular, but also all healthcare workers. Because one of the things we've always done, once there's, for example, an outbreak or there's a suspected case or a few cases have been reported, alerts are sent to all regions, to teaching hospitals, to notify them of the particular disease. And this, one way or the other, heightens the alerts of clinicians, increases the index of suspicion, and in so doing, enable them to be able to take the appropriate measures and ensure that they protect themselves from the disease. Now, case definitions, as we'll go into details later, but basically we are two types or three in some cases. And the suspected case is typically what a clinician would also be thinking once they meet a patient and the patient has presented the symptoms and they've done their examination. Now, for us, the case definition is very loose. And indeed, if you use our case definitions in a clinical setting, like during medical school exams or say a resident, you are presenting to your consultants and you are asked what your suspicion is after a presentation, and the first thing you are mentioning is based on a case definition, you probably are going to get hammered. You probably are going to get very low marks if you're a medical student in an exam. House officer presented, you probably will not be considered serious. And so, but case definitions, suspected case definitions are made loose for a reason. We want to be less likely to miss a case, but that also means that a lot of the persons we suspect may actually test negative. But that is the import of surveillance. We don't want to miss any case. So rather have a lot of false positives or people we suspect who test negative than have a few who then miss quite a number who might test positive later. So clinical diagnosis is very specific, but also more likely to miss a case if we want to be very accurate about diagnosis. So the critical expectation for clinicians here is to be able to compartmentalize clinical diagnosis and the application of case definitions. Have one at the back of your mind, so it should not be at the front, that somebody presents with fever and jaundice, and the first suspicion is yellow fever, especially when we've not had an outbreak. You probably would not be getting the best of feedback from senior colleagues you are presenting to. So it's important to compartmentalize these two. And as we go through the case definitions in the subsequent presentations, we would get a clearer appreciation of why we do this. So what are clinicians to do as far as IDSR implementation are concerned? As I mentioned when we looked at the surveillance functions, the primary role for clinicians, and apologies if I seem to be focusing more on clinicians for the non-clinicians in this workshop, largely because we targeted doctors for this presentation, doctors and physician assistants and other prescribers, our community health officers. It's critically for detection and reporting, because the activities or the actions that follow after reporting are largely within the domain of public health, even though we do involve clinicians at some point, as I've indicated in the last bullet on this slide, where clinicians are expected to lead in the field investigations for cases of priority diseases conditions and priority diseases in case we have a disease outbreak. But clinicians are also best placed to detect any priority disease. If you want to suspect measles, if you want to suspect yellow fever or any other priority disease condition, clinicians are best placed to be able to suspect these and trigger the public health actions better. They are better placed to do this. In addition, if an alert clinician is applying the principles of IDSR, that could make the difference between us recording, let's say, a single case of cholera and a widespread disease outbreak. So it is important that clinicians understand these things. And again, clinicians are in a better position. They provide better opportunity for us to be able to investigate these priority diseases. So how do we strengthen clinician involvement in IDSR implementation in this country? I think the first step for me is us looking at the knowledge and application of case definitions in the clinical setting. It's important that we know, so what are priority diseases? And what are the case definitions? What is expected of us as clinicians? Once we know this and we apply them, then we are going to be having a more robust surveillance system in this country. It's also important that the processes for investigating suspected cases of priority diseases under surveillance in Ghana are understood, and this would give us a stronger opportunity to disease surveillance in Ghana. The other point is about institutional public health units. My experience in CATH shows that if you have a strong public health unit, you can be able to work better with the clinical departments and ensure that the surveillance system and other public health actions, not just surveillance, but other public health activities are stronger in these health institutions. So the knowledge, the understanding, and then the institutional arrangements are key. But in the long term, we're also looking at the strengthening of the pre-service training on not just integrated disease surveillance and response, but also all the public health principles for medical, nursing, pharmacy, and allied health students. I think we all have a critical role to play as far as strengthening the IDSR implementation in Ghana is concerned. So in summary, we say that Ghana has been implementing IDSR strategy since 2002. There are priority diseases, conditions, and events under surveillance in Ghana, and the case definitions for these provide guidance for the public health priority public health diseases. Clinicians have a critical role to play in the detection and reporting of priority public health diseases, and there has to be a strong collaboration between public health and clinical practice to ensure that we have a robust and responsive public health surveillance system. So these are some references I use, and I want to acknowledge the DG Ghana Health Service, the Director of Public Health, the National Data Manager for our Disease Surveillance Department, our National ICT Manager, Dr. Mwakon of the School of Medicine and Dentistry, KNUST, and last but not the least, the Ghana Medical Association for this opportunity. Thank you very much for this opportunity. Over.
Thank you, Dr. Laye, for your concise and excellent presentation introducing integrated disease surveillance and response implementation to us this afternoon. Our next speaker is going to give us a presentation on priority diseases, events, and conditions under surveillance in Ghana. He is a public health physician with the Ghana Health Service, and he is current coordinator of the International Health Regulation for Ghana, and also the One Health focal person for the Ghana Health Service. He is Mr. Azuma Abdul Tawab. Mr. Azuma, we already seen your screen, and you have the audience. Kindly go ahead with your presentation.
Okay, thank you very much, Aisha. Good afternoon to everybody on the call. I'll stand on the existing protocols to make my presentation. So as Aisha mentioned, my presentation is on the priority diseases, events and conditions under surveillance in Ghana. Okay, so this is going to be the outline of my presentation. I have just four. First, we'll have an introduction where we look at some definitions, especially what an event is, what conditions are, and what diseases are. Then we have reasons for prioritizing disease conditions, events in different countries, because different countries have different peculiar situations. So they prioritize their disease conditions based on their needs. Then we look at the priority diseases, events, and conditions in Ghana, which my boss mentioned earlier. We have 55. Try and run through all the 55, then we'll conclude. So to the introduction to some definitions, I think this is just like a dress rehearsal for most of us, because these are definitions that we are familiar with. A disease is an illness or a medical condition irrespective of the origin or source, which present or could present significant harm to animals, humans, and plants. So irrespective of the origin, whether it's from a zoonotic origin, is transmitted from another person to man, is from the environment, is from plants, they are all of importance to us. And then you can see the significant harm. We are looking at animals, humans, and plants, putting together the holistic One Health approach here. So we look at what an event is. According to the IHR, that's the International Health Regulation 2005, an event is defined as a manifestation of a disease or an occurrence that creates a potential for disease. So an event might not be a disease. It's trigger. So a good example of an event can be a chemical spillage. It has the potential of creating disease, but actually not a disease condition. And it can include infectious diseases, zoonotic, food safety or food-related issues, chemical, radiological, or nuclear, and may be transmitted from person to person, from vectors, goods, and through the environment. The third definition we'll be looking at is a condition. This is just a broad description of a state of health that is abnormal, but it's not sufficiently suited to a specific diseases. A good example is the acute hemorrhagic fevers or the viral hemorrhagic fevers, which is a collection of diseases, collection of various viral hemorrhagic diseases. Then the fourth definition, which is our main topic, priority diseases, events, and conditions. They are just a collection of diseases, events, and conditions that we've defined above that are required to be reported through an established system. In this case, we are talking about the Ghana system, which is the IDSR. In other jurisdictions, I think this is the one most of us know, that we call them reportable or notifiable diseases. So we now zoom into reasons for prioritizing such disease conditions. As I mentioned, different countries have different priority diseases that are there to suit their health systems and their challenges. So the first reason will be diseases with high epidemic potential. These are diseases that can spread very quickly from person to person, leading to high morbidity and mortality, and can quickly spread from one geographical location to another. A good example is Ebola and Lassa fever. And since we are talking about high epidemic diseases, we talk about those with high morbidity and mortality associated with them. There are some disease conditions, when you get it, there's a high level of mortality associated with it, and Ebola is a good example. I know most of us on the call, we have yellow cards, which is one of the IHR required cards for international travel, especially for people from yellow fever endemic areas. So another reason is a requirement under the international health regulations. So the international health regulation is a legal binding obligations on countries that explains how countries are supposed to respond to public health threats or public health emergencies in ways that disrupt trade and national travel minimally without disrupting flow of the movement of people and goods as well. So another reason is disease conditions with effective control and prevention interventions available. So a good example in this case is the vaccine preventable diseases like measles and polio. Then we have some specific interventions that are supported by the WHO to help contain or eliminate some disease conditions. So it is important that as we are supporting countries to be able to undertake that, such disease conditions are under surveillance. And a good example is the Global Polio Eradicative Initiative and the agenda to eliminate human transmitted rabies by 2030. There are also some diseases that we have targeted for eradication and elimination. So if you don't put them under surveillance, I don't know how you'll be able to know whether you are meeting your targets or not, and whether your interventions are working. So a good example of that is borrelia ulcer and leprosy. Also, some diseases have been eradicated globally. A good example is smallpox, which it hasn't been reported in a very, very long time. So it is important that surveillance is kept on such diseases, because it's known in this era of bioterrorism, it's important that you keep eyes on diseases that have been eradicated. And Ghana has been guinea worm free some time now. And also, as my boss was making his presentation, he says we are not just looking at communicable diseases, there are also non-communicable diseases that are prioritized in Ghana. And a good example is hypertension, diabetes, and severe malnutrition. So in Ghana, Ghana prioritized 55 diseases, events, and conditions. The list of the priority diseases was selected based on their epidemiological situation, that's the morbidity and mortality associated with it, and also the geographical distribution, the needs of the country, and also the health system available. They are also put into 6 classes or categories, which will, in the subsequent slides, we'll try and go through these categories and the various disease conditions that are under them. So the first one is the epidemic-prone diseases, conditions, or events which require immediate reporting. These diseases, as I said earlier on, epidemic-prone diseases, they are likely to spread fast. So it is important that they are reported immediately, because that will make the difference of us having a full-blown outbreak or just a contained outbreak. And the second class or category are diseases targeted for eradication and elimination. Then we have other major diseases of public health importance. These diseases pose significant stress on our health sector, and they're also important that we keep them under check. Then we have unusual events or conditions of public health importance. Then the third is diseases or events of international concern because of their potential to cause pandemic and widespread disruption of trade and traffic of human beings and goods. Then the last is other conditions or events of public health importance, where we look at adverse drug reactions and the rest. So the first group we'll be looking at are epidemic-prone diseases or events which require immediate reporting. These diseases have the potential of spreading very fast, leading to increased morbidity and mortality, and spreading very fast to other geographic locations. So this is the list, 14 of them. The first one is a condition, acute hemorrhagic fever syndrome, which I also said can be called the viral hemorrhagic fevers, but in the IDSR, it is acute hemorrhagic fever, which consists of Ebola, Marburg, Lassa fever, West Nile, and dengue. Interesting enough, in the last year and early this year, Ghana has recorded three cases of these conditions. Had Marburg in Ashanti region, Lassa fever in Greater Accra, and also a case of dengue in Greater Accra. Then we have anthrax, which is a zoonotic disease, and I'm sure it's still fresh in our minds because there's the outbreak in Upper East region, even though we didn't have human cases of anthrax in the outbreak. Then bacterial meningitis, which is also key as part of one of our epidemic-prone diseases. Ghana is located in the meningitis belt, so it is important that we keep an eye on cases of bacterial meningitis since we are prone to outbreaks relating to bacterial meningitis. Cholera, another familiar face in the system. COVID-19, I'm sure most of us on the call were engaged one way or the other during the COVID-19 pandemic. Dengue fever, diarrhea with blood, that's shigellosis, foodborne illnesses. This is one critical disease, or should I say composition of this, because it has multiple causes. It can be caused by infective agents, it can be caused by chemicals in the food, which can even be as a result of poor handling. So this is one thing that's important, that when we have a case of foodborne poison, we are able to report appropriately. And the good example that comes to mind is the recent yellow CC issue at Oyarifa that resulted in over 53 cases. Influenza-like illness are also part of the epidemic-prone diseases because of their potential to spread fast and lead to pandemics and spread to other places. You can see number 10, monkeypox or mpox, is bolded here. It is not captured in the IDSR, the copy we'll share, but it's one of the diseases that is under surveillance in the country and one of the epidemic-prone diseases that require immediate reporting. Plague, human rabies, diarrhea, and yellow fever, I think is something that most of us on the call know is important and impact on the public health system in Ghana. So we'll go to the next one, which are the diseases targeted for eradication or elimination. These disease conditions usually have effective interventions like vaccinations and drugs that can be used to treat them. And with the necessary interventions and investment made into trying to eliminate or eradicate the system. So it is important that we keep surveillance or an eye on them to see whether the interventions we put in place are working or not. Then on the list, the first is in alphabetical order. First is Buruli ulcer, which has a very, antibiotics that work very well against it. Guinea worm, which I've mentioned that Ghana has been certified as guinea worm free. Leprosy, lymphatic filariasis or Diesases. Measles, rubella has a very effective vaccine. We have a strong EPI program. So when the immunization coverage is high, we are able to have some herd immunity and able to provide some protection for the populace. Then neonatal tetanus, poliomyelitis, the global polio eradicative, and it's one of the funded programs that looks at trying to eliminate wild polio globally. Then oncotrachomavirus and endemic syphilis completes that list. So other major diseases of public health importance. This cuts across a spectrum of disease conditions, and their reasons vary. Some are due to the impacts it has on the public health system, others are financial, economic, others are also because of the disability that it comes with. So we have the acute and chronic viral hepatitis, some effective vaccines for them. Acute watery diarrhea in persons 5 years of age and above. Then new cases of diabetes. Diabetes is, we used to think that diabetes was of the world practice, showing that in developing countries now, the burden of chronic disease like diabetes is on the rise, and it's challenging even the infectious diseases that we have in terms of morbidity and mortality. Then diarrhea with dehydration in children and people less than 5 years. Epilepsy, new cases of HIV, hypertension, injuries from road traffic accidents, malaria, malnutrition in children under 5, non-neonatal tetanus, schisto, and the list continues. You can see new cases of TB, multi-drug resistant TB, and extremely drug resistant TB. And okay. So the next group we'll be looking at is unusual events of public health importance. These usually point out to an outbreak of an unusual disease in the community. As Dr. Lai mentioned earlier on, in event-based surveillance, these are some of the things that we look at. So a cluster of deaths in the community, either in humans or animals. In humans, if you are in the emergency in 1 week, you see one community, about 20, 30 BIDs from, the same community, and the circumstances of their deaths looks unexplained. And this is one of the things that should prompt you to, notify the public health institution or the surveillance officer to have some investigation into it. Cluster of animals or death, that's avian influenza in birds. You see the birds just dying off unusually. Then a cluster of unwell people or animals with similar symptoms. So a physician, you are in your consulting room, I think the what do you call it? You see people presenting with, flu-like illness. Group of people reporting from the same community or households. This is something that should trigger you to let them have some investigation into. Or it's a boarding school and a bus full of boarders are brought to the hospital, having some diarrhea and vomiting. That should let you trigger the health system. Then chemical events, now that we are having the petrochemical industry is now booming now. There are going to be a lot of chemical spillages. I mean, this is going to affect the fishes and subsequently the workers and everybody in that area. And also the issues relating to artisanal small-scale mining, where the use of mercury and other dangerous chemicals are used for mining goals. In the workers, they are exposed to the risks of getting some diseases. And I mean, they may present with some unusual events that would have to trigger the health system. So on my right, you see the recent anthrax outbreak. It's, I mean, an animal that is dead. You can see bleeding from the orifice. Then down there is the Akiati incident of the explosion, in which it's into the chemical events picture. Then we have diseases of international concern. These are the IHR diseases, because any of the other diseases, especially the epidemic prone diseases, when we have a case, we have something we call the Annex B. I mean, the decision-making instrument of the IHR. So we look at the public health impact of the disease. Then we look at whether is the severity. Then we look at interference with trade, and then whether it has a potential of spreading to other areas. But there are some disease conditions that have been listed under the IHR. Even one case of it has to be notified, the WHO has to be notified. First one is human influenza due to new subtype. So we have H3N2. If later the protein, the H or N, there are some changes in it. So since we have H3N2 now, if one day we have H3N3 or something like that, I mean, it has to be promptly reported to the WHO. Then severe acute respiratory syndrome, which I mean have the potential of spreading and causing pandemics. Then smallpox, which has been eradicated. Zika virus, which is a viral hemorrhagic, acute hemorrhagic fever. I mean, it's one of the diseases that was declared a fake in 2016. And any public health event of international or national concern, whether it's infectious, zoonotic, foodborne, chemical, radionuclear, or due to unknown causes, as far as it's causing concern to the country, it has to be notified to the next level, which is WHO. Then other public health events of public health importance. The first one we have here is the adverse drug reaction, which is a response to a medicinal product, which is noxious and unintended, including a lack of efficacy and which occurs at any dosage. So with this, it doesn't need to, the person doesn't need to overdose the medicine to have the reactive at the normal dose if the person takes it and experiences an untoward reaction and presents in the hospital. I know in this case, mostly we try to, treat the person and let the person go. But it's important that we notify the next level, because this is something that will prompt some investigation into it by the FDA. Then the second we have is adverse events following immunization, which is any untoward medical occurrence which follows immunization and which does not necessarily have to have a causal relationship with the usage of the vaccines. So it doesn't have to have any causal relationship with the vaccine. So the person has taken a shot of a vaccination, present with some symptoms of fever, dry cough, I mean, these are things that we should, even though we manage them, it is important that we notify the public health unit so they complete the process. And issues relating to maternal death and perinatal death, I think these are disease conditions that are audited in our facilities, and that forms part of the entire surveillance system. So in conclusion, Ghana has 55 prioritized diseases, conditions, and events under the IDSR. And I mean, clinicians must be familiar with all 55 and report where appropriate. Thank you very much. I think I shall hand over back to you.
Okay, thank you very much, Dr. Abdul Tawab, for your presentation on the priority diseases. We have 55 diseases, and I think we have about 6 subgroups that we put them under. Diseases that's epidemic prone, diseases that marked for eradication or elimination, and then the others. We are going to take the next presentation, which will be on case definition of epidemic prone diseases. The doctor going to do this is a public health physician specialist who works with the disease surveillance department as an epidemiologist. He is Dr. Holali Yawo Gujino. Doctor, we are waiting to see your slides, and then also you can start your presentation. Can you share your slides or?
Thank you very much.
Yes.
I'm sharing the slides. Please, can you see that?
Yes, it can be seen.
Thank you.
Yeah. Dr. Holali is going to have a long presentation. So please, let's bear with him and then give him all our attention. Okay, over to you, Dr. Holali.
All right. Thank you very much. So I want to say a big good afternoon to all who are beginning of the, and I thank my previous presenters because they've done some of my slides for me. So I'll skip some of my slides along the way. All right. So my topic is on the case definition for epidemic prone diseases in Ghana, and the outline is we'll look at this has been done already. Case definition, epidemic requiring immediate reporting in Ghana. Then, because we'll not be able to go through all 5, we'll look at some that are relevant for certain, those that we come across often. So the purpose is to introduce public health, which we have seen much of, but to also equip colleagues and skills to adequately detect key priorities in Ghana. So what is a priority disease? A lot has been said about it already. I just want to point bullet here, if I can use my pointer. Okay, so amongst them, we also have informs the disease. For those 18, we had the Spanish flu or the and that affected then killing around 50 million who were killed in that pandemic. As a human society, when you've had such an experience in the past, to always have your eye on trends. So for us to have illnesses as part of our practice, and particularly having a pathogen surveillance for it, it is not out of the blue, because a lot of history and experience have informed prioritization of this public health surveillance. Okay. So standard case definition, what is it? It's a standard case definition, it's an agreed upon set of criteria. If somebody has a particular interest, specifies clinical criteria as well as epidemiological criteria. The epidemiological criteria to person and time. When it's put together, when we have a standard case, definitions are important to enable us to define or call the disease by the same standard wherever we find ourselves in the territory of Ghana. So to say that whatever I will call a measles case in, say, the South, in Accra, based on this criteria, anybody in any other part in the North, in the Middle, in the West, in the East of the country, similar conditions and there shouldn't be any difference based on our subjective reasoning or thinking that, but based on what we have all agreed upon measles. Definitions generally are
Dr. Gujino. Yeah, Holali.
More sensitive.
Dr. Gujino.
Yes, me.
Yes, just a little.
Hello, yes, I hear you.
Yes, we would be happy if you could reposition yourself. The network at your end is a bit unstable, and so there's a lot of breaking in your presentation. Yeah.
In it. Oh, okay. Sorry.
Yeah.
Okay, is it better now?
Yeah, it's better, but we hope that it can stay on for a while. If it breaks again, we may take Dr. Arthur while maybe we work on the network at your end. Okay. So we will give you we'll have to go on.
Okay, that's fine.
Let's see. All right.
All right. Okay. So I was saying that we have it in three types for the case definition: the suspected, probable, and confirmed. So as you move up from the suspect, you are more sure to the diagnosis in question. Move down, it's more inclusive, yet there's less certainty as to if it's the condition. What's case definition again? I like this slide because it puts out here something that we find in many of our consulting rooms, a case definition poster that hangs there, that has a summary of some of the key or common conditions that you find in Ghana. And so when you see this, know that it is telling you that this is a summary of some things for our use. The slide itself has a very beautiful, by the end of the presentation, I'll bring it to your attention. All right. So we've seen this earlier on from Dr. Tawab's presentation. We have this priority diseases in various groups. This is a IDSR technical guideline 3rd edition, but because there are many, we're only going at a few which have teased out here to the left, and we'll take them one, looking at their case definition. We'll also look at some plans. Okay. So we'll start with AFP, acute flaccid paralysis. which is the entry point function for polio. So a suspected case of FP is any child 10 years of age with acute flaccid paralysis, or any person in whom a clinician suspects polio. A confirmed case is one in which 2 samples have been taken and been isolated, be it the bacillus or a polio has been isolated. So for us to suspect, we need to take at least two stool samples from each case that we suspect to have polio, or from each case that we identify as having an acute flaccid paralysis, irrespective of the cause. And these two stool samples are to be taken at least 24 hours apart. So from detection, we wait 24 hours later, you take a second sample. And the stool will be sent to the reference lab in reverse cold chain. That is to say that you package these two specimens in ice packs around it to make the temperature of the sample, the specimen, between 2 degrees to 8 degrees Celsius from the point that you take it to the destination, which is the reference, which is the lab that is designated for it. It is important to also note that these samples, if you take it, and very important that the clinicians are very much needed for.
Dr.
Okay.
Olali.
Then I'll readjust and then, yes, I can hear you. Hello? Yes, I can hear you. I can.
Yes,
Hello?
so the feedback that we are getting after to present, then Dr. Olali can reposition, then we take him after Dr. Ate's presentation, because the feedback that we are getting from members, they are not hearing you well. So let's allow Dr. Ate to present.
All right.
Okay. Thank you, Chairman. So we hope
Okay,
to
that's fine. That's fine. I'll do that.
Yes, after Dr. Arthur. Dr. Joshua Arthur is going to present on detection and reporting, including laboratory reporting of priority diseases, events, and conditions in Ghana. A little background on Dr. Joshua Arthur. He's a public health physician specialist. He has been with the public health unit of Kamfanachi Teaching Hospital as head of disease control and surveillance for the past 7 years. He recently joined the disease surveillance department of public health division of the Ghana Health Service as acting manager of the National Public Health Emergency Operations Center. His professional interest spans epidemiology, health policy, and infection prevention and control. As I indicated earlier, he's going to be talking on presenting on the detection and reporting of priority diseases, events and conditions in Ghana. Dr. Joshua Arthur, your audience, please go ahead with the presentation.
Thank you very much, Dr. Aisha, and good afternoon to all colleagues. I hope my sound is better.
Yes, please, it's clear.
Okay, I would attempt to enable my video. If it doesn't get choppy, then we can leave it on. All right, so we're going to talk briefly about detecting and reporting. I wished we had been able to take the presentation on the case definitions, but we would run through a session of that quickly, and then maybe Dr. Holali Gujinu can come back to us. Right, so we've heard about the public health surveillance system and the IDSR strategy that we use in Ghana, so we will not draw much on that. I think we have had a bit of introduction to the standard case definitions that Dr. Gujuni was going to delve into. Dr. Lai has covered a bit of event-based surveillance. We'll just look at how we can practically do this in our facilities. And then we will not talk much about this One Health thing, but we'll focus on the role of the lab in detecting priority diseases. Right, so detection, and we may have all the nice surveillance system, the case definitions and all that, but once we are not able to detect through a surveillance system, then nothing even starts. So for communicable and non-communicable diseases, conditions, and events, we use a surveillance system to do detection. And a public health surveillance system is as useful as its ability to detect public health threats, events, or hazards. And I was happy when Dr. Lai made it clear that the role of the clinician is to help with that detection function, because that makes a critical difference between a well-contained potential outbreak and an outbreak that is overwhelming and sort of can crash the whole health system. So as has been highlighted, we implement public health surveillance through the integrated disease surveillance and response strategy. And that is what our whole CPD is trying to explain out as much as possible to us. We've seen the indicator-based surveillance system, and so we want to look at how it works. And it's the use of these case definitions to be able to identify these priority diseases, conditions, and events. The case definitions help us to
I don't know, I'm having some challenge with my network.
The case definitions help us to have the same idea about the conditions that we are seeing. And as was explained, no matter who is looking at a particular disease or condition or event, they would have come to the same conclusion if they are using the case definitions. And again, clinicians are responsible for reporting these priority diseases and conditions and events if they detect them or it comes to their attention. And once the cases are detected, whether they fit the suspected, probable, or confirmed case definition, then they are to be notified and reporting using the standardized tools. And we'll look at what tool we are using now for public health surveillance reporting. I am happy that this issue of case definitions have been well dealt with. And I was looking forward to Dr. Gujini's presentation, looking at some examples so that, especially that apparent conflict between clinical and public health criteria could be put to rest. But I would like to just emphasize that case definitions are agreed upon set of criteria. And it helps us to decide whether a particular suspected disease or a condition or event is in front of us when we are dealing with any person in the facility or community. You would notice that when we take a closer look at the case definitions, they specify clinical criteria. They also give specification on time, place, and person. And so the indicator-based surveillance system really uses these case definitions to offer a structured approach to the detection of diseases, conditions, and events. The proper way to make this work is that they should be available at our OPDs. They should be available in our consulting rooms, on the wards where clinicians are working constantly so that we can quickly refer to them. So that's the thing we want to encourage, so that we don't expect that clinicians should be able to memorize all 55 definitions, but they should be available. And we've seen pictures of the calendar format And in some facilities, you would see the public health unit actually putting out printed copies of these case definitions so that clinicians can quickly refer to them and it can guide whether they move to suspect a particular condition or a disease, upon which notification can be made. So I mentioned the reporting tools for surveillance. And as everything is developing and moving ahead, surveillance reporting also uses electronic platforms. So in Ghana, we are using what is called the SORMAS, which stands for Surveillance Outbreak Response Management and Analysis System. On the left of the screen, I'm showing a case entry interface where details about the suspected case can be entered. A lot of details, including person detail, facility details, symptoms, lab findings, whatever, various contacts, all that information can be put on this. So SORMAS is an electronic platform for reporting on priority diseases. It helps with case-based data entry. Interestingly, SORMAS is linked to reference labs, and so feedback on the laboratory results for these priority diseases are available on SORMAS. I saw earlier on a question about delays in information flow, and the use of the electronic platform is helping to deal with this, because now once the results are put on the system, all levels of the system are able to see the case results, similarly as when the input for the case is put on SORMAS, all levels of the system can actually see details about the case. SORMAS also has analysis capabilities, and so you are able to analyze your surveillance data based on place and time. And it has some mapping ability. So especially when you are picking cases and inputting location data for the case, picking up GPS, you're actually able to plot on the map of the country, the region, or the district where these cases are. And it actually helps with that spatial analysis. Then there is also contact tracing and follow-up, because you can put contact information right there on that platform. And so this is the reporting tool that is now being used for surveillance, disease surveillance activities in the country. I'm showing another interface of it, and here you have the laboratory interface, and you can see that this is a suspected case of monkeypox, and the results have been input on the system right from the lab. And it really sort of helps to eliminate that delay whereby information flows from the facility, district, region up to the national level and has to flow back in the same manner. The system is still in place, it works that way, but because it's electronic, it actually helps to improve that flow of information. I want to touch on EBS, event-based surveillance, and how it operates. So EBS works on what we call alerts, and I think we've had some background on that when Dr. Lai presented. So all healthcare professionals, doctors, nurses, pharmacists, lab, we're supposed to be able to recognize deviations from normal that potentially points to risk to human health. So all these deviations that have risk to human health are termed as alerts. We've got various types, and we're supposed to report them immediately. Examples could be illness amongst health staff after they've taken care of a patient, and now they are exhibiting the same symptoms. It points to something that could mean that potential risk for spread exists for all those that came into contact with this patient. If you have a large sudden increase in admission of any severe illness of the same type, it is an alert. it should point our minds to the possibility that something of risk to human health is happening. You may have severe, unusual, unexplained illness. Maybe we normally would treat this in a particular way, but now it's not responding. It could be antimicrobial resistance. And this is an alert that needs us reporting. We could have in the lab an unusual number of isolates of particular organism. The trend has changed. We are seeing more of a particular isolate than usual. This is an alert, and in event-based surveillance system should be reported. You may be in the pharmacy and you see an increased use of a particular medicine. All these are unusual events, and if you really think about them, they could signal the fact that something strange, something of potential risk to human health is afoot and should be reported. So once such alerts are noticed, they should be reported to the public health unit or department in your hospital. Or if there is nothing like that, then to the district health team or directorate, so that they could take it up, investigate, and decide whether it's something that warrants further action or otherwise. I want us to touch on the role of the laboratory as we detect and report on priority diseases and conditions. So the lab is very crucial in the surveillance system. You would see that when we use the case definitions, we have them to be very sensitive. So you could have disease conditions that have similar signs and symptoms. If you have a child with fever and rash, the case definition works for measles, but you could also be dealing with a potential case of rubella. And it is the laboratory that helps to make that confirmation so that we could reach the confirmed case definition, as we saw in the presentation that we will continue later. Again, the laboratory helps us to identify those pathogens that have the potential to cause outbreaks. Really helps us to decide on the medical countermeasures that would help us to deal with any outbreak that we may be faced with. And for that reason, the laboratory is so important to public health surveillance. Again, we see that a lot of times suspected cases are investigated. Yes, samples may be taken and sent for the lab. But it is also important that we remember that the necessary clinical response measures need to take place even before lab confirmation has been received. And these include managing the symptoms that we are faced with as clinicians. It also involves taking the necessary IPC measures to protect ourselves. So we need to appreciate that role of the lab when it comes to disease surveillance, public health priority diseases, so that even as we are chasing confirmation of what we may be dealing with, it is important that we appreciate that clinical response measures also need to take place even before such confirmation comes. The procedures around specimen collection, storage, and transportation. Sample collection is a responsibility of clinicians. This cannot be overemphasized. Sample collection for the investigation of any priority disease is the responsibility of clinicians. The specimens, as we know, should be properly labeled and packaged. And as we have seen, the reporting tool is the electronic platform called SORMAS. So as a clinician helps to collect the sample, public health officers help with packaging and ensuring that disease or case information is accurately entered on SORMAS. This is important. Otherwise, as our colleagues in the lab will tell us, it's really sets back the ability for the lab to operate and give us results in a timely fashion. We'll dwell a bit on this slide because a lot of times this is where the confusion starts. So what disease or condition are we dealing with? What specimen is to be taken? And where should it be sent to? You have wrong specimen taken for the condition, or sometimes right specimen taken for the right condition, and the sample ending up at the wrong place. So as stakeholders in the public health surveillance system, clinicians also want to be aware that various diseases are tested at different sites. When Dr. Gujuni continues his presentation, we would see that he's tried to put specific labs tied to the specific disease and case definition. So the National Public Health Reference Lab is where samples for cholera will be sent to. For facilities outside Accra, the Zonal Public Health Reference Labs in Kumasi, in Sekondi, in Tamale are also able to do that. A lot of our regional hospital labs are also able to test for cholera, also our teaching hospital labs. You notice that a lot of the diseases that have potential are caused by bacteria are tested with the National Public Health Reference Lab, the Zonal Public Health Labs, and the regional labs and teaching hospital labs. A lot of those that have viral causative organisms may go to the Noguchi Memorial Institute for Medical Research. So influenza, acute flaccid paralysis testing for polio virus, our acute hemorrhagic fevers, Ebola, Lassa, Marburg, and the rest. So we want to be aware of these things so that ourselves as clinicians, even in our facilities, are familiar with this, and we can be sure that the right thing is done. Because we also need that feedback from the lab to really guide our management even beyond the reporting. I want to make an example with bacterial meningitis testing. So collection, sample to be collected is what? CSF through an LP. The idea is to collect 3 ml of CSF into a sterile container. And after that collection, you have to transfer 1 ml of the CSF into what we call the TI medium. I've tried to show a small picture of it there. Typically, TI medium is for culturing. Also, another 1 ml out of the 3 ml collected should be put into a cryotube. And this is for PCR testing. So the sample collected is typically divided into 2. 1 for the TI medium and 1 for PCR testing. If a sample is meant to be cultured, CSF sample is meant to be cultured, should never be refrigerated. So if you need to keep it for any reason, that is why the TI medium is there, and we'll look at that. If we are using the TI medium, once you inoculate the medium with the CSF, it should be sent to the lab immediately. That's the proper thing to do. Sometimes for practical reasons, it's not possible to do that. And so we have a practice of venting the TI medium. You can see there in the picture, the use of a cotton plug needle. And once you're able to do that, we say that the medium is breathing, if you put it that way. It keeps the organism, if it's there, viable, so that the chances of isolating the organism after culture is increased. And then you typically would store at a temperature of 35 to 37 to keep it viable. But within 3 days maximum, the inoculated TI medium should reach the lab. It's not for long-term storage. Sometimes you would go around and you see TI media inoculated that have been sitting somewhere for over 7 days and the rest. And that is not the proper thing to be done. So if you have vented the TI medium because you couldn't transport immediately, then by the time you are ready to transport, it's important to remove the needle, replace the cap, and then transport properly. So transportation to the lab, it's either the CSF specimen is going inoculated in the TI media for culture, or is in a cryotube for PCR testing. It is labeled properly, and then it goes with the case-based form. In a circumstance, it goes with SORMA's entry. The correct lab should be selected on SORMA's, so that the lab, the receiving lab, has a copy of the case information when they open their interface of SORMA's. If you were to select the wrong lab on SORMA system, then it's like sending the paper case-based form to the wrong lab and the sample to a different lab. That's the same thing. So that is something that's important to understand with the reporting and laboratory testing for priority diseases. The other diseases work in a similar fashion. And so I just use meningitis as an example. So let's round up. And I think that with the previous presenters and what we have captured again under IDSR strategy, we have appreciated the role of the indicator-based surveillance system and the event-based surveillance approaches to detect diseases, conditions, and events. We've seen the role of standard case definitions. They help us to make sure that we can consistently detect the same priority diseases, conditions in the same way across the country. We've seen the event-based surveillance system that uses alerts, detection of alerts, and verification for confirmation of public health events, unstructured way of trying to detect whether events that are happening are of public health importance. We also have gone through very briefly the concept of designated laboratories for specific diseases and conditions. And that is important so that we can let the lab play its crucial role of helping us to confirm or rule out our suspected priority diseases and be in a position to put in place appropriate measures. So we'll end here, and this is a reference, the 3rd edition integrated surveillance response. There is a link to access it, and I think the administrator would make this available to us. Thank you.
Thank you very much, Dr. Joshua Arthur, for a brief and yet very informative presentation on the SORMA's and then how we can actually implement the integrated disease surveillance and response. Dr. Holali Gujino would take over. He is going to talk about the case definition of epidemic-prone diseases. All right, so we are waiting for him to share his slide. Dr. Arthur can stop sharing your slides so that Dr. Gujino can do that. So Olali, please, you can share your slides and then continue. Yeah, thank you. Thank you for indulging us and getting a clearer or a better network. Thank you very much.
All right. Sorry for that, but it's all good. So I think we'll resume from the AFP case definition, which we're rounding up. And I was trying to say that it's important to note that clinicians are very much needed in the neurological assessment that's crucial in AFP surveillance. There's need to evaluate to be sure what kind of paralysis the suspected case is having. Is it really flaccid? And that will happen at the commencement or at detection. But 60 days after the onset of this paralysis, there will be a follow-up which needs to be conducted once again by a clinician, preferably by a medical doctor, who will examine this client a second time to have the neurological documentation of the state of paralysis, whether there is residual paralysis or not, and then there will be some others, additional assessment of the muzzle tone and all that. So it's good to take note of this. For AFP surveillance, once again, under some circumstances, specimen may be taken from healthy contacts of the case, which is not routinely done by during outbreaks, and when we have instances of inadequate specimen, we tend to do this just to be sure of what we are dealing with. Okay. The designated lab for AFP for stool samples from AFP cases is Nguchi Memorial Institute for Medical Research. The next is anthrax. So for anthrax, we have at least 4 different clinical presentations, and we'll take them one by one. For the cutaneous, you suspect a case if the client has skin lesion that has evolved over 6 days from a papilla through vesicular stage to a depressed black ischia that is accompanied by edema of the affected area. For gastrointestinal, a person who is presented with abdominal distress, nausea, vomiting, with fever, you should suspect that. Then for pulmonary or inhalational form of the anthrax, the person may have a brief prodromal acute viral respiratory illness, which is followed by rapid onset of hypoxia. You should suspect that, but very importantly for it is when there is evidence of X-ray, on X-ray of mediastinal widening, then you could be dealing with a pulmonary anthrax. Then the meningeal form, not very different from other meningeal manifestations, but in all 4 different forms of the clinical or the manifestation of anthrax, one will want to provide evidence of a linkage with the person having had contact with animals that were sick or confirmed or suspected of anthrax, or handling of animal product, be it skin, fur, hoofs, and other things that we get from animals that could actually carry the spores of the anthrax. For confirmed cases, when there's demonstration of Bacillus anthracis from tissue, be it from blood, be it from the ischia or the lesions, we will have a case of confirmed anthrax. It's noteworthy to have in mind that because this organism is very sensitive to a lot of antibiotics, particularly the penicillin group, we tend not to find them in humans sometimes when there are outbreaks because people resort to all kinds of treatment. Nevertheless, one should beware and know that there could still potentially be anthrax, although the lab evidence has not merely confirmed that. The labs that do this are the Veterinary Service Department laboratories. We have one in Accra, Takoradi, then Pont Tamale, and then our National Public Health and Reference Lab. Samples should go there for confirmation. Cholera. So cholera, we have a definition that spans all the 3 standard case definition we talked about earlier on. We have suspected for anyone who is 2 years or above that is presenting with acute watery diarrhea and severe dehydration or dying from it, you should suspect cholera. In a place where there has not been an outbreak declared. But in the circumstances where an outbreak has already been declared, in fact, for cholera, just 1 case constitutes an outbreak, then the age reference will not be taken into consideration. But anybody at all, irrespective of the age, who is dying from acute watery diarrhea, this person should be considered, or presenting with it or dying from it should be considered as a case of cholera. Probable case. For probable case in cholera, if you have a suspected case and this suspected case tests positive on RDT, we have cholera RDTs in the facilities. This is something that can be done bedside, or if there's not enough for the wards or this thing, you may have them in the labs, the facility labs. If the RDT test positive for 01 or 01309, then that case ceases to be a suspected case, but has moved on to become a probable case. In the absence of this, however, if the case is linked to a confirmed case of cholera, the new case is now linked to epidemiologically linked to a confirmed case, it will also pass for a probable case. For confirmation, however, we will need to isolate the organism by culture or PCR testing to confirm that we are dealing with Vibrio cholera 01 or 0139. In jurisdictions where we have eliminated cholera, and Ghana is aiming for elimination also, then we want to prove beyond just the 01 or 0139 that the type that we are isolating is actually toxigenic. Then you have a cholera confirmed. The labs that can do this, I think my previous presenter talked about them. Bacterial meningitis. So bacterial meningitis, if any person presents with sudden onset of fever, the rectal being 38.5 or more, above 38.5, then the axillary being 38 or more, with signs of neck stiffness, altered consciousness, meningeal signs, suspect meningitis. A probable case would be one that has this presentation of a suspected one, but when CSF was done, it is turbid or cloudy or purulent, or has microscopic, evidence of gram-negative diplococci or gram-positive diplococci or gram-positive bacilli or leukocytosis with 10 cells per microliter or a positive agglutinin test. You should pick this one as a probable case of meningitis. The confirmation will be dependent on the organism that is isolated and from the CSF. And PCR is also done to see the kind of subtypes of organism that we are dealing with. The labs concerned have been talked about earlier, and they are also listed here, the National Public Reference Lab and co. Having said that, however, I want to say that overall in Ghana, the main hub for testing of meningitis is the Tamale Zonal Public Health Reference Lab. That's where most of our work is done and most of the confirmation is done. Acute hemorrhagic fevers, as we've seen earlier, this is a condition embodying so many other conditions. A suspected case will be one that has an acute onset of fever of less than 3 weeks duration in a severely ill person or even someone who has died, and any two of the following, be hemorrhagic or purpuric rash, epistaxis, hematemesis, hemoptysis, blood in stool, or hemorrhagic, any other hemorrhagic symptom, and no known predisposing factor to hemorrhagic manifestation or clinical suspicion of any of the viral hemorrhagic diseases, then you should suspect an acute hemorrhagic fever. A probable case would be one that has an epidemiological link to a confirmed case of an acute hemorrhagic fever. And confirmation will be decided by the type of organism that is isolated. Samples are taken. They run a battery of tests on it, including all the various hemorrhagic fevers. So if you suspect an acute hemorrhagic fever, it's likely it's going to be tested for Marburg, Ebola, Lassa, and all that. And depending on the one that is confirmed, you will get such a feedback. Having said that, I want to say that besides the general or the generic case definition for acute hemorrhagic fevers that we use, we also have specific case definitions that are peculiar to some of the hemorrhagic fevers, be it Ebola, Lassa, and co. So with this, a case may enter in from the perspective of the generic, or it may come in through the specific, depending on what was suspected at the initial point. And the lab that tests for us is the Nubuti Memorial Institute for Medical Research. COVID-19. I think this is a lengthy one, and we've dealt with COVID-19 for a number of months now, so I think I will skip this. What I want to say, however, is that for the lab that tests COVID-19, there are many. We have our regional labs, we have our some of the bigger institution labs, we have private labs, we have the National Public Reference, the zonal labs. The testing is done all over, but all the labs that test, they actually have also been given capacity to input the results or the feedback into the SOMA system nationally. So I'll skip that of COVID. Okay, dengue. So for dengue, suspected case is any person with acute febrile illness, 2 to 7 days, duration, has headache, retroorbital, and then any of these 2 symptoms that we'll talk about, headache or retroorbital pain, myalgia, arthralgia, rash, hemorrhagic manifestations, leukopenia, you should be suspecting a dengue fever. Now, the confirmed case will be when the lab is able to confirm IgM or antibody for the virus, or 4-fold greater rise in IgG, antibody titer, or through PCR, they are able to confirm. And the last one is viral isolation itself. Again, Noguchi does that for us. Rabies. A suspected case of rabies, a person with 1 or more of the following: headache, neck pain, nausea, fever, fear of water, anxiety, agitation, abnormal tingling sensation or pain at the wound site. When contact with a rabid animal has been suspected. You have all these signs, and then there is history of contact with a rabid animal, be it through scratching or bites or any such encounters. You are likely to be dealing with a rabies, therefore you should suspect it. And confirmation is by laboratory testing of brain tissue, particularly from postmortem, skin tissue, cornea, saliva, throat swab, or CSF. It's important to note here that now testing is being done. In years gone by, just the clinical parameters were used to more or less conclude that we are dealing with rabies. But now there's need to confirm taking samples that have been listed here to these labs. The labs involved with rabies testing are the National Public Health Reference Lab, the Veterinary Service Department laboratories in Accra, Tamale, and then Takoradi. Influenza-like illness. Another set of conditions. These are about 3 different conditions here. We have the influenza itself, we have SARI, or what do you call it? And then the SARS itself. So for ILI, we have an acute respiratory infection, which gives us a fever of equal to or greater than 38 degrees Celsius and a cough, and onset is within the past 10 days. You should be dealing with an influenza-like illness. Now, for SARI, or severe acute respiratory infection, it's just like the influenza-like illness, but practically to differentiate, when the person is considerably sick to warrant detention or admission or inpatient management, then it is no longer an ordinary ILI, but you are dealing with a SARI, and therefore we should notify or report as such. Earlier on, the first presentation mentioned that for influenza-like illness, we are running sentinel surveillance, and that is it. So we have all these sites that report routinely on cases of ILI, but the door is open in your facilities, whether your facility is one of those designated sentinel sites or not. If you suspect that a case presenting before you is an influenza-like illness or a SARI, you should also be able to, initiate the system, the process of taking sample and sending it to the designated lab, which is Noguchi Memorial Institute, for testing and confirmation. And the test results will determine the kind of organism or the kind of disease that we are dealing with, since they are different. Then on the ILI again is the SARS. So for SARS, we have suspected case being an individual with a history of fever greater than or equal to 38 degrees Celsius, 1 or more symptoms of lower respiratory illness, cough, difficulty in breathing, shortness of breath, radiographic evidence of lung infiltration consistent with pneumonia or what do you call, or ARDS, that's acute respiratory distress syndrome, or an autopsy finding that is consistent with acute respiratory distress syndrome or pneumonia, or one in which no alternative diagnosis can fully explain this clinical manifestation. You are dealing with a suspected case of SARS. For confirmation, an individual in whom we've been able to test SARS-CoV positive, that is more specifically SARS-CoV-1 before we had a CoV-2, which is now the COVID SARS. Okay. The lab to send a sample to is Noguchi. Suspected case of Lassa. So for Lassa, an illness with gradual onset, with one or more of the following: malaise, fever, headache, sore throat, cough, vomiting, diarrhea, myalgia, chest pain, hearing loss, history of contact with excreta of rodents, or with a case of Lassa. You should suspect it's Lassa. Then for confirmation, PCR is done to determine the presence of the viral, genomic material. In other jurisdictions, IgM can also be done, but for us in Ghana, we generally use PCR. Or if in the absence of PCR confirmation, the case was suspected, but there's a clear epidemiological link with a laboratory confirmed case. Maybe somebody is sharing the same, living space with the husband, the wife, family member living together. Now one is confirmed of Lassa, and the other, for one reason or the other, we've not been able to conduct the test by presenting with symptoms that consistent with a suspected case. Then we will still go ahead to say that, well, this is a confirmed case, even though we have not been able to test in that particular individual. This particular caveat is very useful when we have outbreaks in large numbers, and sometimes we are, our capacity to test is limited. We sometimes have to actually handle it this way during outbreak investigations. Measles, rubella. So for measles, rubella, any person with fever, maculopapular rash, that is non-vesicular, but is generalized, with cough, coryza, or conjunctivitis, or any person in whom a clinician suspects measles. So if you take note of this caveat that was opened up, some of these conditions, the one who is presenting may not present with the classical maculopapular rash, or the maculopapular rash may have been there, but it was altered due to people applying or patient applying all kinds of things on it. But the clinician, having taken the history and examining and looking at even the social history, the family history, and others, concluding that this might be a case of measles, even though we may not have the classical signs and symptoms, the surveillance system will pick it up and is obliged to pick it up and have samples taken for this case to be tested and confirmed or otherwise for measles. Then for confirmation, we do tests for measles IgM or PCR, and once again, a caveat is left open for epidemiological linkage to confirm a case of measles. For measles rubella surveillance, the interesting thing is that whereas primarily we suspect measles, in the event that the sample gets to the lab and it tests negative for measles, we automatically test by way of surveillance for rubella, because we know that these two conditions are very similar and sometimes may not be easy to distinguish clinically. So for everybody. So for all cases that test negative for measles, we test them for rubella. In fact, for cases that test indeterminate for measles also, consistently, we also test them for rubella. And if they turn out to be positive, it is communicated as such. So you start with one condition, measles, but you end up with two different outcomes depending on what is actually causing the illness. And the lab is National Public Reference Lab. Mpox, we've dealt with it recently. So an acute illness with fever greater than 38 degrees Celsius, with intense headache, lymphadenopathy, back pain, myalgia, intense asthenia, followed 1 or 3 days later by progressive development of rash, beginning on the face and then spreading elsewhere on the body, including the soles of the feet and the palms of the hands. You are likely to be dealing with a monkeypox. And probable case is one that has epidemiological link to a confirmed case of monkeypox. PCR is done to confirm cases at the National Public Health and Reference Lab. Plague. So for bubonic plague, a suspected case is a person having very painful swellings in lymph node and fever, and consistent epidemiological features such as exposure to infected animal or evidence of flea bites or residence in place where this disease is endemic, or having visited such a place within the past 10 days, you should suspect a plague in this client. For confirmation, a suspected case has to demonstrate Yersinia pestis from the blood or aspirate from the boobs, or specific seroconversion for rapid diagnostic test kit, that is factor 1 antigen, in places where it is endemic. This disease also has at least about 3 different manifestations. However, it is known that normally you have the bubonic manifestation, then it may progress to pneumonic and septic plague in the individual. So whichever you are presenting with, you have to see to it that we take sample and then send it to National Public Health and Reference Lab for confirmation or otherwise of the case. Yellow fever. So for yellow fever, sorry. All right, so yellow fever. A person with acute onset of fever with jaundice appearing within 14 days of onset of the symptoms. A probable case is one that has epidemiological link to a confirmed case or positive post-mortem liver histopathology suggesting yellow fever. And a confirmed case is one that has IgM testing positive for yellow fever virus. Detection of yellow fever virus specific neutralizing antibody is also used for confirmation. In fact, a number of other tests are used. However, in Ghana, we generally do the IgM. And for further testing, we send samples to Institut Pasteur, where they do other tests, including PCR, to further confirm yellow fever for cases suspected in Ghana. Zika virus. Suspected case of Zika is a person presenting with rash, fever, and at least one of the following signs and symptoms: arthralgia, arthritis, conjunctivitis, non-purulent. And a probable case is one that is suspected with presence of IgM antibody against Zika with epidemiological link, with no evidence of infection with other flaviviruses like the yellow fever. Confirmed cases. A confirmed case with laboratory confirmation in, is one that has Zika virus RNA isolated or antigen in a serum or saliva, or urine, or whole blood. IgM antibody against Zika is also used for confirmation. The print 90 and all that are additional tests that are done in the lab, which are all used to confirm. Okay. The designated lab is Noguchi. It is one of the hemorrhagic fevers, and it is tested for. Then we have hypertension. So to suspect hypertension, any individual who is presenting with resting blood pressure of systolic equal to or greater than 140 degrees, diastolic equal to or greater than 90 millimeters of mercury, you should suspect the hypertension in this client. But it is important to know that we want at least 3 different readings that are consistent with this to conclude. For confirmation too, similarly, we want that any individual presenting on at least 2 separate occasions with a resting blood pressure based on 3 average readings of 140 millimeters of mercury systolic or greater, and then 90 millimeters of mercury or greater for diastolic blood pressure. It's important that because we want to avoid double counting, it is only the first diagnosis that should be reported And not that maybe when the client moves from one institution to the other, or he comes to the same institution on different occasions, some of them are in denial. So when you ask, oh, no, I don't have it. But when you check, you realize that he was here or she was here earlier on, and this was confirmed, you only report it once. Diabetes mellitus, any person presenting with the following symptoms: increased thirst, increased hunger, frequent urination, you should suspect it. Confirmation, any person fasting blood sugar equal to or greater than 7 millimoles per liter, or a person with random blood sugar equal to or greater than 11.1 millimoles per liter. You should suspect. Here again, we should only report the first instance or one instance. The designated lab is our facility laboratories. Most of our facilities have what it takes to confirm this in the clients. So we are soon rounding up. Case definitions, we've looked at just a few of them. We want to draw our attention that there are actually other case definitions, but what we've looked at is the standard case definitions for what we will be using in our institutions. In the community, you may find community case definitions, but that is not relevant for this our session, and we won't go into it. Case definitions can be formulated during outbreaks based on the symptomatology as well as the epidemiological findings of a disease condition during an outbreak. And in an outbreak scenario, because a lot is being learned about a disease, the case definition may be varied over time. This was typically played out when we had COVID at the initial stages, when not much was known about the disease, not much was known about the causative organism. It was changing just to be able to deal with the ongoing, epidemiological situations. But with time, when things are settled, much is known, then, standard ones are agreed upon. Again, sometimes we get outbreak because the organisms have either mutated or gotten some new susceptible hosts in the environment. Therefore, presentation may not be so typical as in what is already known in the standard case definition. So when you have a new subtype of the influenza, yes, it will still present with flu-like illness, but it may have a slight different presentation of what is typically known. And so that happens, and when that happens, and you don't bear this in mind, your case definition may not be able to capture this new pathology that is presenting, quote unquote. So let's bear this in mind so that when during outbreaks you have to vary to take care of the prevailing situation, we'll be able to flow along with it. So this brings us back to what I spoke about earlier at the beginning of the presentation. I said that the, the case definition was something, a poster that I showed earlier on. What we see here is a calendar showing a happy elderly man and a very happy lady on a bike riding through a field. But if you take good notice, you realize that there is our case definition hiding behind this beautiful picture here. And this is because the people here wanted to have access to this picture as well as the calendar, and the case definition was hidden. It is clearer here. You see that the calendar was shifted so that we can see the case definition. But we know that it is not just because of the picture that, they were hanging this thing here. They really wanted the date, the time, so that they could book their client, they could schedule them and all that. But the case definition could also be visible. Having hung the calendar over the case definition was covered and was not accessible to the users of this consulting room. So we had to come to this compromise to cover the beautiful picture, but at least allow the calendar dates to be available for them to do the bookings. And very importantly, to have access to the case definitions that they needed at this very particular time. This very region in which we found this was in an outbreak, and they did not have this thing available for the clinician just because the calendar was covering it. This is one example, but going around, we do find these things a lot. We have people who don't even know that the case definitions are hanging in their consulting room. It is supposed to be there for us to make reference to, because there are many, we can't remember all, but with this, we'll be able to make reference and then be able to detect and report case. So in summary, case definitions are generally loose, making them more sensitive, but less specific. And there is a very good reason why, which was made clear with the first presentation. I want clinicians to always have these case definitions as possible differential diagnosis to their working clinical diagnosis. It will help a lot. And finally, frequent reference to this case definition, be they on posters or in the technical guidelines that we'll be sharing, are very helpful for clinicians to get used to them. In fact, for some of us, those posters were our initiation into knowing what case definitions were. We just saw them in the consulting rooms, and it's like, what is this? What is it about? And it's with time, we're able to get to know that, oh, these are case definitions. They will help us to report on notifiable diseases or priority diseases for that matter. So thank you very much for your attention, and I hope I will be able to address all your concerns. Thank you.
Thank you,
Aisha.
Dr. Holali. Yeah, thank you for a very good presentation. And we thank you for indulging us and changing your network. And it's really been very good for us as well. And those that have their hands up who are trying to ask questions should kindly type all their questions into the question and answer session. So far, we've had all 4 presenters for our IDSR implementation program, or CPD. We had Dr. Dennis Laye doing the introduction to integrated disease surveillance and response, followed by another good one by Dr. Abdul Tawab Azuma, who talked about the priority diseases. And then Dr. Holali talked about the case definitions and some of the issues that arise in our getting the case definition forms and all that. Then Dr. Joshua also spoke about the detection and reporting with some emphasis on the surveillance, the SORMAS. We now come to the question and answer session, which will be taken by the chairperson. So I'll hand over to Dr. Kweku Apj to do the next session. Chairman, over to you.
Okay, so thank you very much. We are grateful to the presenters for the wonderful presentation. As a clinician who is about moving from clinical practice into public health, I really enjoyed it, and I'm sure most of our participants did. Usually for such presentations, when you start, you have the maximum number of people. By 1 hour, 2 hours, you see that the number reduces drastically. But for this one, we have maintained the 1K participants since we started. We've had more than 100 and 400 people join, so I think it's been good. So we will start with the questions. So the first one goes to Dr. Atta. In your presentation, you stated that clinicians were responsible for taking the lab samples for the epidemic-prone diseases. Somebody wants to know, in case the clinician is not available, who should take the sample?
Thank you very much, Chairman. I'm wondering whether I'm the one who is saying that clinicians should take samples, or clinicians by their training and by the law that guides their practice know that they are supposed to be taking samples. So I don't want it to be, I am the one saying that. So again, I don't know whether I should make it a political answer and ask, what happens when the clinician is not there to manage a case? What will we do? So I really don't want to answer that question because I don't know how I would make the clinician's responsibility someone else's responsibility because they are not available. I think that if there are foreseen circumstances where a qualified person may not be around, I'm not sure that we can summarily do task shifting on things that border on skills and competence. So I am a bit at a loss how to answer that question. But I'm just referring all of us to the fact that it is a clinician's training and responsibility to take samples, clinical samples.
All right, thank you very much, Dr. Arthur. So the next question goes to Dr. Dennis Lai. Dr. Anita Agol says, this has been a very relevant workshop. Are there any short or medium-term plans beyond what is already being done to support clinicians in health institutions to appropriately detect and report these priority diseases after this workshop? Is this just a one-time engagement, or your department is looking at engaging clinicians further in the coming years? Thank you, Dr. Lai.
Yeah, thank you very much. I can't tell you how excited I am at this meeting. You've mentioned the numbers as well. It's something that would have taken us, I don't know, months to be able to achieve this number of especially doctors in one go. So believe you me, we intend to go the long haul with this. We would organize sessions that would look specifically at some of these priority diseases. So for example, we intend to look at acute flaccid paralysis, go into details, what the surveillance system expects. I think that this is just an introduction. So we'll be working with the GMA on this and make sure that we get as many of our colleagues very much in touch with what is expected. I think that beyond that, I mentioned in the expected outcomes that beyond this workshop, we expect active participation, but we also want to look at the training institutions in particular. Because when you go to medical school, management of hypertension and ectopic pregnancy, we're taught all these things. But I think that the public health practice bit is missing, even though we do a lot of community health. I mean, I did community health for 5.5 years. So I'm just wondering how it is that we come out and it looks like there's a disconnect between what we are being taught and what we're practicing. So the department is taking that up as well, and we're going to look at working with the training institutions as well, with the pre-service training. If we talk about the residency training in public health, for example, it's something that we do in there. So that is not an issue, but that is just a small group of doctors who, for want of a better word, have actually taken up public health. So it's expected that they know this. So there are a lot of ideas we have, and we're definitely also open to some more ideas on how to make this work. I believe strongly that if we have clinicians very sensitive to our surveillance system, there will be no need for activities like records reviews to find out whether we've missed cases, because we don't expect clinicians to miss these cases. They are the ones who will see them first. So quite a number of ideas, but yes, thank you. I think that we would work with all the relevant stakeholders to see how we can get this to the level we'll consider optimum. Thank you very much. Over.
Thank you very much. So we just had an assurance from the Acting General Secretary of the GMA, Dr. Richie Selumi. He says the President and the National Executive Council of GMA is willing to continue to partner you to help to share this knowledge and expertise with our members and all other health workers. So that's a good assurance from the National Executive of the GMA. The next question comes from Dr. Sami Latte, an orthopedic surgeon. He wants to know what interventions the team is putting in place for road accidents victims who are involved in RTAs, since we seem to have a lot of such cases in our system. Is there a way you can use data to convince government to put in interventions? And the public health part, is it just beyond the numbers? What exactly are you doing, especially when it comes to road traffic accidents, being part of the diseases that you look at in the public health space? Any of the speakers can take this, please.
Okay, maybe I'll respond to this, because I probably in a in some time past wore the program manager for non-communicable diseases hat, which diseases included road traffic injuries. So it's actually one of the areas where, as a country, we don't do too well. And there have been efforts to get 3 key agencies to look at this issue. The National Road Safety Authority, the Police, Motor Traffic and Transport Department, and the Ministry of Health. We, together with the WHO, looked especially at issues around disparities in data reporting. One of the things we ought to remember is that road traffic injuries are one of the key priorities as far as the Sustainable Development Goals 3 is concerned, which is looking at health, and particularly 3.4, which looks at NCDs. And we've actually, the key challenge here has been data, the quality of data. Reporting road traffic injuries has depended a lot more on the National Road Safety Authority and the police department rather than the health system. And again, we've had challenges with the classifications, the interests as far as some sections within the clinical community is concerned. Should we report just the injuries, or should we go into specific details? So somebody has a fracture of the middle finger, that specific information is what somebody wants. Others think that once we aggregate the data, it should be fine. So the engagements are still going on. And I think that it will be good to work with groups like the orthopedic surgeons as well, so that we can find common ground. But as it is now, every road traffic injury that is reported to a health facility is captured. And the utility of the data, as I said, with some of these gaps has been quite a challenge, but we are happy to address these. I've put my email address in the chat box, so I'm happy to engage colleagues beyond this meeting. The NCD program manager, Dr. Ifa Kome, I'm also aware, is on this call as well. Maybe with her permission, I'll share her email address as well, so that she can also be contacted to look at this. Those would be my responses. Maybe colleagues might have something to add on. Over.
Okay, so we'll go to the next question from Emmanuel Sari. Please, what do I do as I'm in a facility where medical officer fails to report suspected cases of this sort in the name of people who will not patronize care if they get to hear of such cases, and to the extent of mixing TB cases to normal admission? Cases. So in what do you do in case, can a medical officer refuse to report such cases even when the person is suspecting such a case?
I think so. One of the things we haven't gotten to that point here. In other jurisdictions, it's expected. Indeed, it's an offense, and you could face the regulatory agency if you fail to report a notifiable disease. We don't have that in our statutes yet, and I think that it's important that we uphold our clinical practice, our Hippocratic oath enjoins us to ensure that we don't do harm. And part of doing harm is not reporting a disease condition or managing the patients in ways that would prevent others from getting the disease, or alternatively put others at risk of getting the disease. So I think that we don't have the legal regime now. Would encourage colleagues to do this. There's a health security law in the offense, so maybe that's something we can consider as one of the sections in that law to ensure that clinicians report these. But as it stands now, it seems to be, for want of a better word, a voluntary way of reporting. But I think that we should also be guided by our practices to report such, and also manage, I think, the potential fallouts, because sometimes, yes, people have genuine concerns, and if we don't address them, it's a two-way thing. If we don't address them, then it could also limit people's confidence in the health system, and that can be counterproductive. So I think that we need to manage these. But also, in the situation that was painted, I think that it will be good that the doctor engages the district health management team to see the best way around this. I don't think this should be escalated to the national level, but if need be, as we indicated, we are also available to support. Thank you, Nova.
Okay, so for most of the questions have been answered, or they have been answered in the Q&A session. So we are not going to read all. The next question is from Florida Banson. What's the feedback? How do clinicians get feedbacks for suspected cases that they report? I have had experience with the ILI and SARI. You get your email from Noguchi, which is prompt. But she wants to know, for other of these priority diseases, how do they get the feedback? And does the feedback even get to the clinician in the consulting room at all? Thank you.
Right, thank you. So I think Dr. Arthur and colleagues have mentioned that we're using an electronic platform currently. One of the advantages of this platform is that it affords everybody to see the result at the time, everybody related to that case, I should qualify. So everybody related to that case to be able to see that information when the lab has the results ready. So in times past where we needed to go through regions to districts to facility, that time is gone. If we have a suspected case of measles and the sample is taken, the disease control officer enters the information on the platform. Once the National Public Health Reference Lab tests and the results are ready, they will put it on the platform. And so the disease control officer, at least every district disease control officer, every district director have access to this platform, and they can get the results and communicate same with the clinician involved. So that for now is how we are transmitting the information, and is instant, as I indicated. Once the result is put on the platform, the disease control officer can be able to see. And that's why that collaboration between the clinical team and the public health team is important. It's probably not practical to have all clinicians in this country, all public health people on this platform. We don't have the bandwidth or the capacity to do that now, but at least there are designated officers across all the levels. And these officers, once we liaise with them, we should be able to get the results promptly. Thank you, Anova.
Okay, so our dental colleagues want to know, is there any dental condition that forms part of your priority diseases? If yes, can you just list a few?
Well, I think as far as the list we provided are concerned, there's no priority dental condition in there. And I also saw an indication, I think there was a question about rheumatic fever, rheumatic heart disease. Yeah, rheumatic heart disease and pediatric non-communicable diseases. When Dr. Tower presented, he highlighted the basis for sometimes prioritizing some of these disease conditions. And so we need to make a case for including some of these conditions in there. And as I mentioned earlier on, these are things we are still open up for engagements to discuss further. There are colleagues in the dental field who have done public health as well. And I think that they can, based on their training, be able to give us better guidance on how to include some of these conditions which we think should be prioritized in our priority diseases list. So this is still open for discussion, and we can be able to discuss these beyond this meeting. Thank you, Chair.
Okay, so we'll be taking our last 3 questions. So Olivia Usubuahe, thanks for the education today. Is there any existing data sharing arrangements? If yes, how are surveillance and other pandemic data shared with the WHO? If Dr. Azuma can repeat his answer.
Okay.
Yes. I think I answered it earlier. There is an arrangement where we share the weekly IDSR data with the WHO and also the epidemic prone disease conditions. Anytime we record a case, we have something we call the IHR decision-making tool. We use it to, assess the public health impact of the reported cases, its severity, whether it's going to cause disruption to trade and traffic, and potential international spread. So there are 4 questions. If you get 2 and above, then we have to immediately notify WHO within 48 hours after confirmation. But I also gave a list that contained wild polio virus, the human influenza new type, Zika virus. Those ones, immediately you record a case of it, you are immediately expected to notify the WHO through the IHR platform. Thank you.
Thank you very much. So quickly, somebody wants to know, who bears the cost of testing and transporting samples of these priority diseases? Is it the clinician? Is it the facility? Is it the health directorate? Is it national?
So without giving a very simple answer, let me say this, that one of our biggest challenges with our disease surveillance system remains a reliable transport system. So we're using multiple now. For example, with our Sentinel surveillance, there's a pre-paid system. And then for our priority diseases, the testing, once the samples get to the designated labs, so all the labs Dr. Gujino indicated, once the samples are sent there, it is not tested at the cost to the patient. Again, district directories have a responsibility to transport samples from facilities to the regions and thence to the designated national testing laboratory. Facilities as well can make their own arrangements. Our internally generated funds can be used to pay for the transport of samples to the designated lab, and these should not come at a cost to the patient. And I'll say this, no audit query has ever been raised to any health facility that has sent samples, has used facility resources to pay for the transportation of samples for public health purposes. And so there are multiple options, even though I was the first to admit that we have some challenges with transport. There are still options that can be explored, but this should not come at a cost to the patient under consideration. I also have to say this, because I mentioned designated lab. So if you send, say, a suspected case of meningitis to a teaching hospital lab or a private laboratory, then it's going to come at a cost to the patient. But if it's sent to the designated lab, then the patient will not pay for this. So that's the other caveat I want to add. Thank you very much. Over.
Okay, so then we'll take the last 2 questions. So somebody wants to know, what efforts are in place to get data from the private sector, i.e. private clinics and hospitals and community pharmacies, especially on NCDs and other priority diseases? What efforts are in place and what are you doing as a service to engage the private sector, the pharmacies, especially on NCDs?
Right, thank you again. I'm very happy with the questions that are coming up. So this gives me a lot of hope that if we continue these engagements, we're likely to see a better surveillance system. So in times past, even the implementation of surveillance has been restricted for want of, largely to Ghana Health Service facilities. Colleagues in teaching hospitals, quasi-government hospitals would know that sometimes the engagements have not been the best. We have started a process, and we did have a special session for just teaching hospitals and quasi-government hospitals. One of our key objectives in a new funding we are working on with the Global Fund is to look at engaging private health facilities to strengthen their role in the implementation of disease surveillance, not just for epidemic-prone diseases, but also for non-communicable diseases. And so the engagements will continue, and we want to get to the point where the reporting is across all the sectors, private and public sectors. So that is something we have in mind, and we are grateful that it's also come up in this meeting. Thank you very much once again. Over.
Yes, another problem that people have identified is getting the disease control officers to come and pick up samples after they've been taken. So maybe in our discussions, we should also look at that. We have that concern on our YouTube channel. So asking that at times it takes a lot of time for you to get the disease control team to come and take the samples and transport it to where it's supposed to be transported to. The last one will be, you answered it, but I would want everybody to hear it. So there's a question from a very senior colleague, Dr. Agongo. Please, has the SORMAS been linked to the DIMS database now? Because we still have that issue. People ask, the data from here, is it a centralized system or the data is just for Ghana Health Service? So he wants to know whether the SORMAS has been linked to the DIMS database. Now, you type your answer, but I would want the participants to also hear the answer as well, since it's a very important question that has been asked.
Sure, thank you very much, Chair. So the SORMAS, as Dr. Atta mentioned, is our electronic platform for collecting surveillance data. And DIMS, as far as we use in Ghana, is for aggregated data. What exists now is that, so for example, disease A, let's say measles, the information is entered manually in DIMS now after it's been aggregated from SORMAS. The plan is to make it seamless. So once we have the data in SORMAS, there's a communication between the two. And so the summary data will be available in DIMS as well. It's been piloted for COVID-19, and we are in the process of working to develop what the IT people call an API or an adapter, so that the two can speak to each other for all our priority diseases. And once this is done, it will go live, and it will reduce the risk of any data entry errors. So it's not ready yet, but it's work in progress, and we hope to get it done as soon as possible. Thank you, and over.
Thank you very much. So I think time is far spent. Usually for public health related CPDs, you have people leaving early, but as we've noticed today, because the presentations have been good, we engaged our members, and our members want to know about more of the public health priority disease and assist in dictating them. We've had them stay on for a very long time. We are happy to the GHS team. I think initially the engagement was supposed to be for 100 people, and we've been able to get more than 1,300. We thank you. We thank all four speakers for your good work, and the committee will continue to engage you So we'll be waiting to hear from you for the next CPD session that you want to have. Our doors are always open, and would assist you to educate our members better. And once I'm also becoming a public health person, it means I have to have a soft spot for the public health unit. So the acting chairman will have a soft spot for you whenever you need our services. Kindly let us know and would assist you. House, we want to thank you for staying with us throughout almost 3 hours. We are grateful. We are happy to see the majority join, not just because of the CPD points, but because they really wanted to gain and to update their knowledge. We are grateful to the house.
Chairman,
Dr. Aisha.
Yeah, before you conclude, the evaluation form has been posted in the webinar chat. So everybody who is still on can kindly fill out the evaluation form before concluding, before leaving. Okay.
Please, I think we also made available a link to the IDSR technical guidelines. So if it can be shared.
Okay, yes. So would put that as well. So please, let's do what to do the evaluation process, and also look at the IDSR. It helps a lot. I've been using it, so it helps, especially when you are in the clinical setting. So Dr. Aisha, thank you very much. I hand over to you for you to get us somebody to have the closing prayer, then we can sign off. Dr. Lai and team, Dr. Atta, Dr. Waben, my boss, Dr. Olali, we are grateful. So Dr. Aisha, we can conclude. We can close.
Yes. Have one of the panelists say a word of prayer to conclude the session on our priority diseases under surveillance in Ghana, in our bid to implement the IDSR. Panelists, I can see our GMA Secretary, Dr. Richard Salome. Please, could you do us the honors of giving us the closing prayer?
All right. Thank you very much. Shall we pray? God, our Heavenly Father, we are very grateful that you have granted us the opportunity for life, and also for these great presentations and learning session that we have had today. We thank you for the knowledge that we have gained, expertise that we have gained. We pray that even as we live, you continue to bring this in our memories and also materialize them in our practice, so that in the end we'll all do well to help curtail some of these priority diseases and make our health system better for us all. Be with us all as we begin the week, and make the week successful and pleasant for us all. In Jesus' name we pray thanksgiving. Amen.
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 Yes.
Amen.
Thank you, committee members. Thank you, GMA. Thank you, Ghana Health Service. Thank you, all participants, for taking your time and then contributing to this CPD. It's 6 points. Yeah. Bye-bye.
Remember to fill the form before the
Yes, please remember to fill the evaluation form. Thank you very much.